All right, welcome to this explainer. Today, we're putting on our academic ophthalmologist hats to really unpack the fundamental pathophysiology of ocular inflammation. We're going to provide you with some highly actionable, real-world surgical pearls for prescribing topical corticosteroids and NSAIDs. We'll be rigorously comparing these agents, but we're going to do it by focusing on three absolute pillars: their specific mechanisms of action, their unique bioavailability profiles, and, crucially, their adverse drug reactions, or ADRs. So let's take a quick look at today's roadmap. We are going to start with pathophysiology, move right into corticosteroids, then hit topical NSAIDs, and we'll wrap the whole thing up with a clinical comparison.
Section 1. Pathophysiology, the arachidonic acid cascade.
Okay, so ocular inflammation doesn't just happen in a vacuum, right? It requires a catalyst. That could be mechanical trauma from something like cataract surgery, an aggressive infection like uveitis, or a systemic autoimmune trigger. But to actually treat it effectively, you really have to visualize the physiological waterfall that causes it. When tissue is damaged, cell membrane phospholipids are cleaved by an enzyme called phospholipase A2. This cleavage releases arachidonic acid, which is basically the primary fuel for inflammation. From there, this waterfall splits into two very distinct rivers: the cyclooxygenase, or COX pathway, which pumps out prostaglandins, and the lipooxygenase, or LOX pathway, which produces leukotrienes.
Now here is a massive surgical pearl for you. When you're in the OR, as surgical trauma inevitably occurs, inflammatory mediators are instantly released into the eye. Prostaglandins synthesized right down that COX pathway we just talked about are the specific culprits that trigger unwanted miosis, that's pupil constriction, along with severe conjunctival hyperemia, or redness. Look, if your patient's pupil aggressively snaps shut mid-cataract surgery, you are in for a very, very difficult case.
Section 2. Corticosteroids, the upstream blockade.
If the arachidonic acid cascade is a raging river of inflammation, I want you to think of corticosteroids as a massive upstream dam. The exact mechanism of action for all corticosteroids is the direct inhibition of phospholipase A2. By blocking this very first enzyme, you prevent the release of arachidonic acid entirely. It's a total upstream blockade, effectively shutting down both the COX prostaglandin pathway and the LOX leukotriene pathway right at their shared source.
But as you know, not all upstream dams are built the same. We classify these drugs by their pharmacological design. Ketone steroids, like prednisolone and dexamethasone, feature a C20 ketone group. Their MOA powerfully blocks phospholipase A2, absolutely, but that ketone group forms irreversible covalent bonds with lens proteins. That is exactly why their primary ADR is being highly cataractogenic. Conversely, we have ester steroids, like loteprinol. Loteprinol utilizes that exact same MOA, but its ester-based bioavailability makes it what we call a soft steroid. It basically has a built-in self-destruct switch for rapid metabolism into inactive forms once it's inside the eye, and that significantly reduces the ADR risk of dangerous intraocular pressure spikes.
Now, there is a critical distinction we need to make between raw pharmacological potency and actual clinical efficacy. Let's compare dexamethasone alkyl 0.1% to prednisolone acetate 1%. On paper, dexamethasone has a much higher raw potency, but its bioavailability relies on a hydrophilic solution, which has relatively poor corneal penetration. Prednisolone acetate, on the other hand, while less potent on paper, has a highly lipophilic suspension bioavailability. This allows it to penetrate the intact corneal epithelium beautifully, yielding aqueous concentrations over 20 times higher than dexamethasone. It's a perfect example of how superior bioavailability creates superior clinical efficacy.
But of course, that heavy-duty efficacy carries some profound risks. The signature adverse drug reactions of corticosteroid therapy absolutely demand your respect. Because they suppress the immune system so thoroughly, you risk secondary fungal or viral infections, as well as delayed wound healing. And more insidiously, as we mentioned, they cause posterior subcapsular cataracts. And they physically alter the trabecular meshwork outflow dynamics. That leads to steroid-induced glaucoma through severe IOP spikes. So these patients require close, incredibly careful monitoring.
Section 3. Topical NSAIDs, the surgical workhorses.
If steroids are that big upstream dam, NSAIDs are our highly targeted downstream filters. They are our true surgical workhorses. Let's lock in their MOA. NSAIDs completely bypass phospholipase A2 and instead specifically target and inhibit the cyclooxygenase enzymes, COX-1 and COX-2. This halts the synthesis of prostaglandins, which, remember, are the mediators of pain, vasodilation, and meiosis, while leaving that LOX leukotriene pathway completely untouched.
Clinically, we leverage this highly targeted MOA across the entire surgical timeline. Preoperatively, we're using drugs like flurbiprofen. Its bioavailability as an aqueous solution makes it absolutely perfect to drop onto the eye before surgery to inhibit trauma-induced prostaglandins. That prevents the surgical meiosis we discussed earlier. Its main ADR is just some mild stinging. But postoperatively, we rely on innovative drugs like nepafenic. Nepafenic's unique bioavailability is that it's actually a prodrug. It remains inactive on the ocular surface, which minimizes toxicity, but it penetrates deeply into the posterior segment, where intraocular enzymes finally activated.
And why exactly do we need nepafenic to reach the posterior segment? To fight cystoid macular edema, or CME. This is a devastating post-surgical complication where inflammatory mediators cause fluid-filled cysts to literally swell up within the macula, destroying central vision. Postoperative NSAIDs are the absolute gold standard of care to prevent and treat this specific prostaglandin-driven fluid accumulation.
So, the crucial takeaway here is that while NSAIDs don't cause cataracts or IOP spikes, they do have their own dark side. The standard ADRs are stinging and conjunctivitis. However, the most critical vision-threatening ADR of topical NSAIDs is corneal melting or thinning. It's a rare but absolutely catastrophic complication, and it's particularly dangerous for patients with pre-existing predispositions. We're talking about your patients with diabetes, severe dry eye, or a history of herpetic keratitis.
Section 4. Clinical comparison, bioavailability, and risks. Okay, we've covered the isolated pharmacology. Now let's synthesize it for that actual patient sitting in your chair. When recovering from surgery, the eye's internal blood-aqueous barrier is severely compromised, leaking proteins and cells. Surprisingly, when it comes to reestablishing this specific physiological boundary and halting that fluid leak, clinical data shows that our targeted NSAIDs actually frequently outperform our broad-spectrum steroids. But here's the reality check. The best drug in the world fails if the patient doesn't use it correctly, which brings us to the ultimate intersection of bioavailability and patient compliance. Remember prednisolone acetate? It's a suspension. The drug particles literally settle at the bottom of the bottle. If you don't explicitly instruct your patient to shake it vigorously, they are basically just dropping expensive water into their eye. Solutions like dexamethasone don't need shaking, but they have lower penetration. And then we have modern marvels like difluprednate. Its MOA is a PLA2 inhibitor, but its bioavailability is an emulsion. It requires zero shaking, which ensures perfect dose uniformity and massive patient compliance. However, its extreme potency means its ADR profile carries a fierce risk of IOP spikes.
Now, this matrix right here is your ultimate clinical anchor. Notice the delicate balance. Steroids target phospholase A2, but their major red flags are glaucoma and cataracts. NSAIDs target COX-1 and COX-2, but their absolute red flag is the risk of corneal melting. You literally have to weigh this scale for every single prescription you write.
And please, do not forget the eye is attached to the rest of a human being. Systemic recall is vital here. Ocular drops drain right through the nasolacrimal duct straight into systemic circulation. Long-term use of topical steroids can significantly elevate a patient's systemic blood pressure and blood glucose. Topical NSAIDs, conversely, offer a vastly safer systemic profile, which is a big deal for your vasculopathic patients. So I want to leave you with this final provocative challenge. Knowing the profound differences in mechanisms of action, bioavailability, and red flag ADRs, the very next time a patient with a history of fragile diabetic corneas or maybe borderline open-angle glaucoma sits in your chair post-surgery, how exactly will that history alter your prescription pad? Apply these pharmacological principles, protect your patients, and thank you so much for joining me for this explainer.